Welcome back to Roadmap to Residency. In this video, we are tackling pregnancy complications, but we are doing it the smart way. We are not going to reteach all of obstetrics. Instead, we are going to show you how the board questions are written and how to attack the stems you will actually see on test day. We will work through bleeding in early pregnancy, preeclampsia and delivery timing, gestational diabetes, and preterm labor. Keep a trusted obstetrics review resource and your question bank open alongside this video because the real learning happens when you apply these strategies to practice questions. Here is our game plan. First, bleeding in early pregnancy, where the whole game is separating a miscarriage from a tubal pregnancy. Second, preeclampsia, where finding severe features tells you exactly when to deliver. Third, gestational diabetes screening. And finally, preterm labor and when to give medication to stop contractions. For each topic, you will get a strategy, a realistic practice question, and a full walkthrough of why the right answer is right and why every wrong answer is wrong. Let us start with first trimester bleeding. When a pregnant patient bleeds early, your very first move is to decide if she is stable. Low blood pressure, a racing heart, severe one-sided pain, or shoulder pain should make you think of a ruptured tubal pregnancy, and that patient needs the operating room, not more testing. If she is stable, you pair the pregnancy hormone level with a pelvic ultrasound. When the hormone is high enough that a pregnancy should be visible inside the uterus but the uterus looks empty, you think tubal pregnancy until you have proven otherwise. That single pairing of the hormone and the ultrasound is the engine behind most of these questions. Now preeclampsia, and here the STEM will hand you the answer if you know what to look for. Scan for severe features, a blood pressure at or above 160/110, a severe headache, vision changes, pain in the right upper part of the belly, low platelets, or rising liver and kidney numbers. Any one of those means severe features, and that drives your timing. Without severe features, you are aiming to deliver at 37 weeks. With severe features, you deliver at 34 weeks, and you add magnesium to prevent seizures and medication to bring down dangerous blood pressure. If she is earlier than 34 weeks and both mother and baby are stable, you add steroids for the baby's lungs. On to gestational diabetes. 3 patterns show up again and again. First, the routine screen happens between 24 and 28 weeks with a 1-hour sugar drink test, and if that is high, you confirm with the longer 3-hour test. Second, if the patient is high risk, with obesity, a prior large baby, a family history, or previous gestational diabetes, you screen at the very first visit, and even if that is normal, you still repeat the standard screen later. Third, treatment starts with diet and exercise, and when that is not enough, insulin is the classic next step in pregnancy. Watch for answers that jump to medication before diet has had a fair trial. Let us put the bleeding strategy to work. A 26-year-old woman at about 7 weeks comes in with bleeding and cramping. Her vital signs are normal and she is comfortable. The pregnancy hormone level is 1,800. The ultrasound shows no pregnancy inside the uterus and a little fluid in the pelvis. The question asks for the next best step. Notice she is stable, and notice the empty uterus at a hormone level where you would expect to see a pregnancy. Look at the 4 options and decide before we walk through it. Here is the reasoning. The hormone level is high enough that a normal pregnancy should be visible inside the uterus, but the uterus is empty and there is pelvic fluid. In a stable patient, that is a possible tubal pregnancy, not a clear miscarriage. Because she is stable, you confirm before you act. Repeating the hormone level in 2 days and re-examining tells you whether the values rise normally, plateau, or fall, and that is what separates a failing uterine pregnancy from a tubal pregnancy. Calling it a normal miscarriage ignores the empty uterus. Rushing a stable patient to surgery skips a safe confirmation step. Cervix ripening medication treats a miscarriage you have not proven and could harm a tubal pregnancy. The answer is to repeat the hormone and re-examine. Now a preeclampsia question. A 30-year-old woman at 35 weeks comes in with a severe headache. Her blood pressure is 165/112 on repeat readings, and there is protein in her urine. The baby looks reassuring. She is started on magnesium and blood pressure medication. The question asks for the next best step. Find the severe features and find the gestational age. Then choose from the 4 options before we go through them. Let us reason it out. The STEM gives you severe features. A blood pressure at or above 160/110 plus a severe headache. At 35 weeks, this is preeclampsia with severe features in a pregnancy that is already late enough to deliver safely. Remember the rule. Severe features after 34 weeks means deliver. Magnesium and blood pressure medicine stabilize the mother, but the only cure for preeclampsia is delivery. Waiting until 37 weeks or sending her home leaves severe disease untreated and risks seizure, stroke, and separation of the placenta. Simply observing without a plan is the same mistake. The answer is to deliver the baby. Now, preterm labor and the medication we use to slow contractions, called tocolysis. The key idea is that tocolysis does not keep a baby inside for weeks. It buys you about 2 days, and you spend that window on 2 things that genuinely help the baby: steroids for the lungs and transfer to a hospital with a newborn intensive care unit. Just as important is knowing when not to stop labor. You generally offer tocolysis between 24 and 34 weeks, but if there is serious infection in the womb, heavy bleeding, severe preeclampsia, or a baby in distress, you do not delay delivery. In those stems, the answer is to deliver. Here is the preterm labor question. A 28-year-old woman at 30 weeks comes in with regular painful contractions and a cervix that is opening. She has no fever, no bleeding, and the baby looks reassuring. She has not yet received steroids in this pregnancy. The question asks for the next best step. Think about the gestational age, the reassuring baby, and the fact that steroids have not been given. Pick your answer before we walk through it. Let us work through it. This is true preterm labor at 30 weeks. The baby is reassuring, and there is no reason to deliver right now. That is exactly the window where you give steroids for the lungs and use tocolysis to buy about 2 days for those steroids to take effect. Going straight to delivery throws away the steroid window when nothing is forcing an immediate birth. Giving tocolysis but skipping steroids wastes the very time you just bought. Sending her home ignores a cervix that is already opening. Steroids and tocolysis belong together here. The answer is steroids plus medication to slow the contractions. Before we wrap up, here is a filter that works across all of these obstetric questions. First, ask whether the mother and baby are stable. Unstable vital signs, heavy bleeding, a baby in distress, or a ruptured tubal pregnancy all push you toward acting now and often delivering. Stability tells you whether you have time to test and confirm or must move immediately. Then, once she is stable, let the number drive the plan. Gestational age decides delivery timing in preeclampsia and the window for steroids and tocolysis in preterm labor, while the pregnancy hormone level and the ultrasound decide your move in early bleeding. Find the number in the stem and the right answer usually follows. That is your strategy session on pregnancy complications. Drill these patterns in your question bank until the next best step is automatic, and read the full explanation for every question, even the ones you got right. Pair this video with a trusted obstetrics review resource so the underlying material sticks. If you want more help, visit roadmaptoresidency.com, where our expert tutors and residency advisors can build you a personalized study plan. If this video helped you, please like the video and subscribe to the channel for more board review content. Good luck on your exam, and we will see you in the next one.